So I want this to be very informal. I hope we can have a little bit of discussion to signal the informality. I'm going to take off my jacket because it's kind of hot in here. But yeah, as Bill mentioned, I came in from Michigan, where I'm the director of a program at the University of Michigan called Quality Improvement for Complex Chronic Conditions. And what QUIC does, QUIC is both within the university and in the VA. I've been in the VA for about 17 years. So both groups had an interest in forming a center that would develop really practical solutions to problems in chronic illness care. And my focus has always been on diabetes as kind of an exemplar, but more and more we're looking at patients with other chronic diseases and multimorbidity as well, because that's what makes someone complex. Every patient with diabetes is complex because their regimen is complex. They have multiple things going on at the same time. They have socioeconomic barriers oftentimes. They have language barriers. They're newly diagnosed. They have comorbid depression. All of that complexity is what we worry about in our research center. And in particular, you know, when I started this group, I thought, what is really motivating me? What am I thinking about after doing interventions for diabetes for over 10 years? This was my conclusion, that patients just need a whole lot of help, right? And there's the gap. And yes, you know, now you say that, and yet you see the heads start to nod. These are two studies that were really important in my thinking in recent years. The first one is by someone down in this part of the country, Lisa Rubinstein. Lisa Rubinstein is at UCLA. She's also in the VA. That's how I know her. And she's developed huge multi-dimensional interventions for depression. That's been her prototypic chronic disease. And they've been amazing. I mean, it has all the things that we know now that work for chronic illness care. Registries, tailoring about medications to the providers, between visit support for patients, and she's done huge multi-institution randomized trials and shown that, in fact, you can really improve the quality of depression care with these interventions. But guess what? No one does them because they're way too expensive. Okay, so Stephen Dobscha, who's another great VA researcher, he did what we're being told to do a lot in general now in the research world, but especially in the VA. Be translatable. Translate things. Don't do things that can't fit in the real world. Do things that can actually work in real life practices. So he took Lisa Rubinstein's interventions and trimmed it down. Trimmed down the amount of between visit support for patients, cut out some of the elements of tailoring for providers because the providers didn't have enough time, and tried to repackage it in a way that it would actually work and fit with reimbursement structures. So they did another huge, rigorous, randomized trial of the intervention. No effect. Nothing. So there we are, right? We have things that have a big effect, but no one is willing to pay for. And we have things that you could actually do in real-world practice, but they're not strong enough to really have a benefit. So this is an example of this phenomenon from the heart failure world. These are not studies. I'll tell you what these aren't. These are not studies that show that telephone care management improves outcomes for heart failure. Each of these is a review of studies that show that telephone care management works for heart failure. That's how many times we have shown. Each of these is reviewing multiple randomized trials that show that you can improve either rehospitalization rates or mortality for heart failure with between visit support for patients. And yet, here we are, we don't do it. So that's the gap. I mean, we know in many cases what works, but we have this problem of not being willing to pay for. So why do we keep having these same things again and again and again? It's kind of like this. Time, in fact, is not on our side in primary care. Now, this is, I think, a really telling slide, because you think if Mick would get up in the morning and he'd look at himself in the mirror, he'd say, you know, I got to stop singing that song. It's just not true anymore. You know, time is not on my side. And it's like us in academia. You think we would stop producing interventions that don't work in the real world, but for all kinds of reasons, that's what people do, because they really need to publish. They want to publish something that has a big impact. And we're supposed to do things that work in the real world, but that's kind of secondary. So we keep singing that same song, just like Mick keeps singing the same song, because he's got other reasons to sing the song besides the fact that it's true. There was a couple of really important articles early this year that, again, kind of looked at this problem or the situation we're in. This is the type of data that I'm sure you're all very familiar with looking forward in the next few years. How much is the prevalence of different chronic diseases going to increase by 2023? So here's diabetes, 53% increase in prevalence, okay, while the population is only growing 19%. So diabetes is going to go up a lot. It's going to go in cost from $132 billion to $430 billion. Okay, so the costs are going to go up. This is only going to get worse that way. And when we look at the workforce we have in primary care, for example, the nursing workforce, this is what you see. Each of these curves is the average age, or the age distribution of nurses. What does that tell you? Nurses are getting older. Okay. They can't take it anymore. No one wants to do that job. You'd have to be crazy. Who in their right mind, right, would go into primary care or go into nursing? It was such a difficult job, right? So no one's going into those things anymore. So we have this, right? This is a recipe for disaster. We have this increasing number of patients. The provider pool is shrinking. This is where we're getting at the theme that I said that keeps me up. We're in a time of scarcity now, and it's only going to get worse, okay? Are there really important studies that came out at the beginning of the year? Medicare did a lot of demonstrations around things that we thought would help. Care management type interventions. This was one of those studies. This wasn't too encouraging. What did it say? Programs that included provider-based, third-party, and hybrid models, reducing costs sufficient to cover the program fees has proven challenging. Final evaluations on 20 programs found only 3 with evidence of quality improvement at or near budget neutrality net of fees. Okay? You don't save money with care management. People aren't going to jump in. You know, we all hope we do, and we think we will in diabetes in the long run. But payers aren't excited about getting into this area. Even look at the things that we all know we want to do. Taking medication for chronic disease. This was very sobering. Okay? Over the 4 decades since cost effectiveness analysis was first applied to health and medicine, hundreds of studies have shown that prevention usually adds to medical costs instead of reducing them. Medications for hypertension, elevated cholesterol, diet, exercise to prevent diabetes, and screening and early treatment all add more medical costs than they save. Right? Great, great news, right? So we're looking at a time where Lisa Rubinstein, who did the depression study, if you noticed, she wrote an editorial, and after the Stephen Dobson study, that said, there's no free lunch. These people are sick. We need to get in there. We need to help. And I totally agree with her. But that's a tough sell right now. What I would like to talk about in the next 45 minutes or so is this. First, I was asked to talk specifically about one type of scarcity, and it's a type of scarcity that I've really focused on in a lot of our research, and that's medication costs and how that affects diabetes patients and other patients' adherence. Okay? So I'm going to talk and review some of the data on cost-related medication underuse. Then I want to talk about an area in particular that's been very interesting to me, and that is what are the other aspects of a patient's life or how they're thinking about their disease that affects how they respond to medication cost. Because despite everything that I said, I've tried to be very optimistic and I try to be very practical in thinking, what can we do? And for the clinician on the ground, it's often very difficult to change what someone's copayment is, right? But I believe that there are things, and I'm going to show you some data that suggests there are things that we can do to help patients take their medication despite the cost that they incur, okay? And then specifically, I want to even more talk about what clinicians can do to help, okay? So that's our agenda. Now, this lovely place is near a place called Santa Cruz de Yojoa in Honduras, where we do a lot of research on diabetes screening and on how patients in other countries in Latin America are being affected by our financial crisis and money not being sent home. But I included it here because it's a big picture, and I want to focus on the big picture. So occasionally we're going to come back to the big picture just so we have a chance, so people can ask questions and we can have a little bit of dialogue. Okay, so first, medications and financial pressures. We've done a number of different studies, and I'm going to show you 3 separate surveys of patients asking them, how are they being affected by their medication costs? Okay, we did one major survey over the internet with over 5,000 chronically ill patients. We did another survey in Northern California with patients from a variety of healthcare systems. And we recently looked at data from a national survey of more than 26,000 chronically ill people. So I want to show you some of those data about how many people are cutting back on their medication because they say it costs too much. So first, this is from that first survey that I said of 4,000 patients. And it was a typical sort of design that we use. We asked patients, are you cutting back on your medications because it costs too much? Have you done it this last month? Which of your medications are you cutting back on? So just to walk you through, here's diabetes patients right here. If you look over here, 19% of diabetes patients in this study that was conducted back in 2004, 2003, said that they cut back on their medication because it cost them too much, almost 1 out of 5. And 15% said they do it about once a month. Now specifically, about 1 in 10 was cutting back on their diabetes medications, okay? So that's way too much. That says 10%, 15%, maybe a little more in this survey, were cutting back on their medication because it costs too much. Unfortunately, the other data that we have from our studies, from other studies, shows that those are underestimates. Those numbers are too low. When we looked at a sample of diabetes patients in Northern California, here's what we found. Okay? VA patients, now those patients have pretty good prescription drug coverage. That group was less than 10%. But if you looked at patients with private insurance, you were getting closer to 20. Patients with Medicare, 30. Medicaid, 30. And of course, uninsured patients close to 40%. Okay? That was diabetes patients overall saying, I'm cutting back on my medication because it costs too much. When we looked at them by whether they had comorbid diseases, right, and likely were taking a lot of different medications, of course, not surprisingly, the ones with 3 or more comorbidities, those were the patients that were really, really hurting. 20% for patients with good private insurance, cutting back because it costs too much. Over 30, over 40 for Medicare patients. So this is before Medicare Part D, and I'm going to show you some Medicare Part D and how that's changed, but staggering numbers of diabetes patients saying, I can't take my medication because it costs too much. The recent survey that we did asked patients about their medication cost problems in 2007 and 2008. 17,000 people under 65. We looked at that group separately because now Medicare Part D patients are different. And there's a lot of numbers on this slide, but let me walk you through it. Look at the numbers after the slash. That's the number of patients that said, I had that problem in 2008. 36% of patients with a job, okay? Chronically ill patients with a job. 1 in 3 said, I delayed filling a new or current prescription because I couldn't afford it. 1 in 4 people with a job said, I did not fill a new prescription at all because I couldn't afford to do so. Not surprisingly, when you looked at people that were looking for a job, right, in Michigan, we got one of the highest unemployment rates in the country, so that's a group that's really of interest to us. It's really the real unemployment rate is Michigan, close to 20%. In Detroit, it's over 25. Okay, so this is not an insignificant group. Half of those people said they were not, and these are chronically ill people, right? Now, the numbers before the slash, that was an interesting question. We said, okay, but is that problem worse since the financial crisis began than before? And what the fractions basically show you is roughly half of the people that are having these problems said it's even worse now than ever, right? So it was worse in 2004. It was bad in 2005. It's worse now, even for the people with insurance, and the financial crisis has just exacerbated this problem. So it's a big crisis, medication costs, and a lot of people are cutting back because of cost problems. Just to go back for 1 second, medication costs, of course, affect more than people's adherence. And these people were asked a lot of other questions. This is just 2 of them here. Spending less on basic necessities of life, such as food or heat. Look at those numbers. 32% of people with a job say, I'm spending less on basic needs. 46% of those looking for a job, with half of them saying that problem is worse in 2008 than the year before. Okay? So people are really hurting because of their medication costs. Are they talking to clinicians? Right? That's a good question. Now, in one of the survey that we did in 2004, when patients said, yep, I'm cutting back because it costs too much, this was the next thing they were asked. Did you talk to your clinician? And about 600 people in that survey said, I cut back because it costs too much. So it was something we were interested in. We knew that from prior studies there was an issue in how patients communicate with their clinicians about medication costs. Okay? This study from JAMA showed that patients and physicians think it's important, but only 35% of the doctors and 15% of patients say they ever talk about this. Okay? And they did a survey of physicians, prescribers, and found that 80% of them were unaware of the costs that patients were experiencing. Okay? So when we did our survey and we asked patients, are you cutting back on medication because it costs too much? Only 32% of the patients said they told a doctor in advance, I'm going to stop taking this medication because it costs too much. And a third of the patients who were cutting back because they couldn't afford their med ever mentioned it to their doctor. Okay? And we asked, you know, did you discuss this with your doctor, and looked at what were the types of patients the doctors were talking about medication costs with? The only factor that was related was patients' race. Not how much medicine they were taking, not their income, not their total out-of-pocket cost burden, right? Busy clinicians were screening based on patients' race and making a decision, oh, I bet this guy who's African American is having a medication cost problem, so I'm going to talk to him. The most obvious thing you could think of to do for people that say they can't pay for the medication because it costs too much is reduce the cost of their medications, okay, obviously. And that's a really important thing to do. But one of the studies that I showed you before, I mentioned that we also have data for the over 65ers who have access to Medicare Part D. Now, that was the biggest effort that we've had in recent history to lower patients' medication costs. So how are those guys doing, right? Over 65, first of all, you know, given the change in the economy, 25% of the people over 65 in this study were working, right? Can't afford to retire. 1 in 4. Of that group, a third of them reported some form of cost-related underuse. These are people over 65 eligible for Part D, and almost half of those said that problem was getting worse. Okay? Among those who were retired, over 65, right? This is our new Medicare group. 28% reported some cost-related non-adherence, okay, including things like I didn't fill a new prescription at all because I couldn't afford it. I'm spending less on basic needs. So lowering people's costs is an important thing to do. And we should keep looking for ways to do it. But again, realistically, in the world that we have right now, that's not necessarily going to solve the problems, or we can't wait for that. So that's why I have gotten very interested in this issue, what we call cofactors, the things that influence people's response to medication costs. And there is one study that really illustrates this point on how we can improve people's adherence despite the costs that they inevitably will occur. This is a large national study that's been going on for a long time. It's called the Health and Retirement Study. And the Health and Retirement Study is like 10,000 Americans. They're enrolled when they're about 50, and they follow them through retirement. It's funded by Social Security. And they happen to ask, did you ever cut back on your medication because it costs too much? So this was one of the first studies that got me very interested in this area. And I'll walk you through what it shows. What these are the numbers that people focus on a lot in these early studies of medication costs. And what do these numbers mean? These numbers show that compared to people that had incomes under $10,000 a year, incomes over $20,000 a year, those that had incomes under $10,000 were almost 4 times as likely to say, I'm cutting back on my medication because it costs too much, right? Same thing for medication costs. Compared to people that weren't paying very much, people that were paying over $100 a month, 3 times as likely to say, I'm cutting back on my medication because it costs too much. Those are very important policy things. But again, my reaction is like, no kidding, you know? If you're poor and your medication costs a lot, you don't take them. You know, we know that. Those aren't interesting numbers to me. There's other numbers here, though, that are very interesting to me. What this number says is that if you control statistically for what people's costs are and what their income was, racial minority patients in this study were still almost 3 times as likely to say, I cut back because it's costing me too much. So, which is to say, statistically, have 2 people with the same incomes and the same medication costs, this person says, I'm cutting back, that's too much, and the other person is still taking theirs. Here's another interesting number. Again, we see it's, of course, the proportion of people cutting back because of cost is higher among the low-income patients. That's no big surprise. But in this particular study, even in that group, it was only 16% of people under making $10,000 a year or less. So why are they different than the other people that are making under $10,000 a year that didn't say, I cut back because it costs too much? This is this issue of cofactors and what else is influencing some of the choices that people are making. It's important about their adherence, and it also gives us some insight in how people are thinking about their disease and their self-management. So we developed a whole framework and saying there's a whole bunch of things that influence how the relationship, you know, those are the obvious stuff. Your income, your medication cost, the other costs of your health care, whether you got coverage. We know those are going to affect your adherence. But there's all this other stuff in there that's in the mix when people are making those decisions. And a lot about our research has been on what all those other things are, because some of those we think we might be able to influence. So one of these is socioeconomic and cultural characteristics of the person. So you could say that when we say racial minority patients in the health and retirement study were 3 times as likely to cut back, that's in that box there. That's saying certain groups of people might be responding to medication costs differently, and we should start to understand why that is. Okay, this is just kind of an aside, but I thought this was really funny. I saw this at the VA last week. It was like Employee Appreciation Week at the VA, okay? So someone put up a whole billboard about how great it is to work at the VA, and they put it right outside the cafeteria, right? And they had this quote, why do people come to work? Many say it's the money, but if pressed to reflect, they admit that the money is not what makes them complete. It's the difference they make for others during the course of their work day. Franklin Delano Roosevelt once said, "Happiness is not the mere possession of money. It lies in the joy of achievement, in the thrill of creative effort." Now, this is right out of the VA cafeteria, right? Where the people are making the sandwiches and mopping the floor. I thought that's, you know, that's a kind of flowery. But then I looked down below and somebody wrote this: "Trust me, it's the money." And I thought that was great. Because I was thinking, that's the reality. But it also relates to kind of, you know, the gap that we can have between clinicians and patients around this whole issue of medication taking. We think medications are such a great thing. And they're saying, you know what? We're not necessarily on the same page. We did a study in Flint, Michigan, so that's a really economically stressed area. It was a study funded by the American Diabetes Association. We asked patients about how they felt about different aspects of their pharmacotherapy, their medications, and the results were actually quite astounding. The sort of beliefs that patients were endorsing. People who take prescription medication should stop their treatment for a while every now and again. 16% of people said that's true. Most prescription medications are addictive, 34%. Right? Do more harm than good, 1 in 5 patients. Now this one, who here would not necessarily agree that that's sometimes true? If doctors spent more time with patients, they'd use less prescription drugs. So lots of people saying this, and when we looked, differences, the African American patients, the more likely to be endorsing these beliefs. They're the ones writing, "Trust me, it's the money," at the bottom. We're not on the same page as you, is what these people were saying. Twice as many African Americans patients saying it's good to give your body a rest from all of this medications, right? Much more African Americans worried about this issue of addiction. Okay? So this is how people felt about their medications overall. And when we look specifically at generic medications, which I'll show you next, that was even more astounding. Now, generic medications, when people talk about medication costs and controlling medication costs, generic medications are like fundamental. I mean, that's what we really, really want. But when we ask patients the view of generic medications, again, we are not on the same page. Generic medications are not as good as the original brand name drugs. 31% said that's true. Okay? Okay for some people, but they're not the real thing. Contain dangerous additives. And here, I sent this to a friend of mine that works at Blue Cross Blue Shield, where they're pushing generic medications. Insurance plans push generics to save themselves money at the expense of my health. Most people saying that, especially the African American patients. Now, when you think about it, again, the person that wrote, "Trust me, it's the money," is looking at this and thinking, what planet are you from? Now, if you think of a normal person's experience with generics, generic macaroni and cheese, generic toilet paper, in what world is something that costs a fifth as much just as good? Okay, we have 2 cars. One costs $30,000, one costs $8,000. Oh, trust me, it's just as good. It's the exact same thing. In what world is that true? Right? And now you have a group like African Americans who have been concerned about being denied access in all kinds of areas of their life. And their doctor writes them a prescription for a branded drug. And they take it to the pharmacy, and the pharmacist says, "Oh, well, you know what? I'm not going to give you that. We're going to give you this other thing, but trust me, it's just as good." Right? They're not on the same page. And that is in the soup when people are saying it costs too much, you know, their beliefs about their medication. And it relates in part to trust. Okay? Here's another great story. I just happened to read this on the plane. Old guy and his wife are in bed. The old guy says, "You know, I'm reflecting on our life together." He says, "Maggie, you were with me when the letter came and I had to go off to war. You were with me when I got my pink slip and I lost my first job. You were with me when our house burned down, and you were with me when I got my diagnosis of diabetes. Maggie, you've given me a lot of bad luck. Right? Now, most people don't say that about their spouse. Maybe some do, but people do say that about their doctor. I go to the doctor, I get bad news, right? And this is the reality, right? They're not on the same page, right? They're not having the same experience that the doctor would have. We looked in one of our studies on how trust affected patients' response to medication costs. So it was the same sort of thing where we asked patients, are you cutting back on your medication because it costs too much? That was the main outcome. And we had a very detailed measure, standard measures of, do you trust your clinicians? Do you trust they're doing the right thing for you? They put your interests ahead of their own financial well-being, a scale. We divided people into people that trust their doctor and diabetes patients that don't trust their doctor. And what we found was not surprising. In this group of patients with diabetes who don't trust their doctor, the more their medication costs, the higher the percent said, I cut back because it costs too much. No big surprise there. That same sort of thing happened in people that did trust their doctor. But if you compare across this way, it's a lot less. Okay? Money matters, but twice as many people here were willing to hang in there and say, this is kind of costing me a lot, but my doctor is a good guy, she's a good woman, I trust her, I'm going to keep taking it. When we looked at the same sort of relationship by the patient's income, and this was in the VA, by the way, these are VA patients from across the United States. Same sort of thing. The poorer the patient was, the more likely they were to cut back on their medication costs when they didn't trust their doctor. If they did trust their doctor, there really wasn't any relationship between how much they made and whether they cut back because it cost too much. Okay? So in terms of cofactors, we were able to show that trusting your doctor, right, $10 is a lot of money if you think this person is giving you something that you fundamentally don't need. So again, that's a positive message to me. That says that as a clinic, as a clinician, there's things that you can do to help patients with their medication cost problems, even if you can't reduce the costs that they're experiencing. So I think that's a good thing. So a few things now. What can clinicians do, or what are we thinking about ways to help? So we have this situation, and we have this scarcity, and the patients are struggling with their medication costs, and there's just not enough clinician time to do all this education face-to-face, and we see that patients just need a whole lot of help. And that's the kind of context that we're working in thinking about a few different approaches that we can use and that we think are fruitful. And by and large, it has to do with, connections and connecting patients more with information in a time and place that they can use it in manageable units. And a lot of that has to do with using information technologies and technologies that patients can use. But I'll never forget, this is a story that I tell often because it was another one of these events, like seeing the study by Lisa Rubinstein. It had such a big impact on me. I was speaking at a conference at an International Diabetes Conference a few years ago in Paris. And it was on a panel on technology. And this guy was on the panel, and he was an engineer from the French aerospace department. And who knew that the French had an aerospace department, but they did. And he got up and he said, well, we're not one of the leaders in aerospace, so as engineers, we have to show that we're developing useful things that are useful to society, and that's what we do. And I've just developed something that's really great. And he began to describe that he had developed something that he said, if you say this boy is in the middle of the Amazon jungle, he can wear this around his neck, and if he has type 1 diabetes, it will monitor his glucose, and it will beam it to a satellite so that if we're here in Paris, we can go online and see in real time what his glucose levels are, okay? And my reaction was, I can hardly think of anything that this kid would need less than a necklace that would beam his glucose levels to some guy who's sitting in Paris, right? And that's the way a lot of technology is. And so we're always catching ourselves because there's a lot of cool apps, like cool, out there. And so we need to think of new ways to use technology for our patients that really makes sense. And I feel that you can line up all the things that have been tried on a continuum according to how linked they are to patients' real-life communication with people that matter to them, their clinicians, their family, and you can just line up the studies, and the more linked they are, the more effective that those interventions are. The less linked they are, the less effective. So here is standalone websites or things that you can call in an automated system, and it'll motivate you to walk. Study after study after study after study with cool apps has shown that people use those like 3, 4, 5 times and then stop, right? So I'm sure some of you have used. I mean, they have websites for new mothers or, groups to help you lose weight or to change some other behavior. You go 1, 2, 3 times and then that's it, right? It'll leave a message on your voicemail to say, eat more broccoli or, seriously, and people, it's not linked. They're fine ideas, but they're not linked and they don't affect behavior. Way at the other end was someone, Russ Glasgow, who Bill knows very well, developed something for in a clinic waiting room where the patient would enter information to set a behavioral goal for their diabetes. It makes a printout. They walk it in with their doctor. They both sit down. They read it together. They walk over to an educator who sets up a plan for follow-up. That had incredible effects, bigger than almost anything that's been tried in technology. And it really kind of lines up that way. So we're thinking of technology, but thinking of how we can make it fit. And as I think of how we can kind of rally all these resources that we need, knowing how strapped clinicians are, we have to think not only linking patients with their clinical team, but linking them more with other patients and with informal caregivers. So family members, including family members outside the home. We have to do it all, right? A big problem when we develop a lot of behavioral interventions is that people become kind of in a camp. They say, oh, I think Kate Lorig's thing, that's what we got to do, Group visits. We need group visits, right? Group visits are great for some people. Some people are not group visit people, right? So we just have to do a lot of different things. And that's another part of kind of our motivating philosophy. We think a lot of people need a whole lot of help, and there's no one size that's going to fit all. We would never say, we're going to develop the new hypoglycemic medication that works for every patient in the exact same dose, right? That would be absurd. No one does that, right? But when we kind of develop these interventions, people become kind of believers in one mode or another. So one of the areas that I'm very interested in is this idea of helping informal caregivers or family members outside the home. And it builds on a lot of research that shows that family members, on the one hand, can be very, very effective in helping someone with chronic disease. Clinicians kind of know that implicitly family are really important. Clinicians also kind of have a love-hate relationship. They don't want to have all their family members calling them, right? Because they're busy enough with the patients. So family members can be very, very useful. Other research by another good colleague of mine and Bill's, Larry Fisher at UCSF, show that family can also be very toxic. Okay? I have a friend who lives in Mexico, and she told me not long ago, she says, yes, my mother has diabetes, and she hides candy around her house. But I'll tell you, when I find it, I punish her. Right? And the research that we have shows that that's poisonous. I mean, that's almost more, has a bigger impact in someone's diabetes control than the positive things. Negative, nagging, obstructionist family are bad. So family are in there and they matter a lot. The problem is that when we think of family caregivers, like spousal caregivers, we kind of think of like, well, this person is a spouse. And we have a patient, and then we have a spouse. But that's not the real world. This is other data from that health and retirement study, okay, that was looking at, you know, that the differences in cost-related underuse for minority groups, et cetera. These are people with different levels of memory impairment, and these are the characteristics of their spouse, right? So basically what this shows is spouses are not like caregiver and patient. They're two people living together, both struggling often with a chronic disease as they age, right? So we cannot rely only on spouses to pick up the slack. So people with, if the husband has normal cognitive function, half of those spouses have hypertension. If you look at patients who were demented, over 70% of the patients had hypertension. Other problems, diabetes, no big surprise, lung disease, heart problems, cancer, stroke, psychiatric problems, and a third, incontinence, arthritis, right? It's just old too. It makes sense if you think of it that way. It's not patient and caregiver. It's two people growing old together. And when you look at geriatric patients or any kind of patients, there's competing demands, and we have to look beyond that. That's why this is becoming more the norm. I think it's very cute, right? Most people between, you know, say 25 and 60 relate to this situation. Right? You have an aging parent somewhere, right? My coworkers, our secretary at work has to always take Fridays off because she has to drive to the other side of the state where her dad is living alone, is getting demented, and she's the caregiver. She lives 3 hours away, but she's got to go there and take care of him, right? So family is around. We often have more fractured families. We don't all live in the same area, okay? We live in Michigan. My family lives in Michigan. My parents live in Wisconsin. My wife's parents live in Hawaii, right? That's normal, right? So this is the situation. So how do we kind of build connections given that we have family that lives far away? And that's what this program that we're developing called the Care Partner Program. It builds on a lot of what I've done for many years with trying to use accessible technology like automated telephone calls, right? Because everybody in the world now has a phone. And that's kind of the interface to talk with anyone. I mentioned before that I do things in Honduras and other places in Latin America. 80% of the people in Latin America have a phone. There's 250 million people in Latin America who live on less than $3,000 a year that have a phone. Amazing. Africa is one of the leaders in telephone technology, right? So phones are ubiquitous. It is the interface that everyone can relate to. So we've done things with automated telephone calls for a long time with feedback to clinicians. And now we're looking at ways to use that sort of interface as one way to help monitor people with diabetes and give feedback not just to their clinical team, but also to family members and link those family members in a more effective way and give people access to outside services. You know, in this time, you know, we're in a time of great scarcity. And I hope we have healthcare reform, but it's not going to fix all of these problems by any stretch. At the same time, I mean, our experience has been that this is, I've seen a real shift in that both funders of kind of developing new services and actually clinicians are realizing the kind of straits we're in and are much more open to saying, let's just try. And this is just one example of the type of things that we're trying with people in primary care practices. And, you know, I say, look, we don't know if this is going to work. So far, it's working very, very well. We're doing in the Cleveland VA with heart failure patients. We're doing with Spanish speakers with diabetes around the state of Michigan. And it's gone very well. The patients like it. The clinicians like the feedback and that sort of thing. But, you know, people are kind of coming together saying, let's just try. And so, you know, I'm seeing that some of these issues of you know, people just feeling so burned out they can't do one more thing, has kind of changed. You know, where we're hitting a lot of roadblocks in how people are thinking about, you know, what they could imagine doing next. And so this is kind of a time of a lot of real creativity. And so hopefully, I think we'll see a whole diversity of programs. Like I said, we're not going to have one new drug that fixes it. We're not going to have one new program that changes things for people with diabetes. But I'm actually pretty optimistic that over the next few years, we're going to see a whole number of different things kind of coming out that will hopefully make things better for people with diabetes and for their clinicians that are really, really strapped out there and working real hard. So I'll leave it there. So thank you very much.